Bismillahirrahmanirrahim. Hi everyone. So we are still in the section of abdominal pain causes that usually are not very revealing in abdominal imaging, and we talked about 4 big categories, and now we are at the 5th one, which is kind of a miscellaneous causes, including metabolic causes, endocrine causes, and some other less common genetic causes of periodic abdominal pain. So these causes in general, some of the underlying pathophysiology lies within the inside of the abdomen still, and in other situations it's actually outside the abdomen. So some of the common causes that you might encounter include DKA and uremia. Both are relatively common causes of abdominal pain, recurrent abdominal pain. With adrenal disease, adrenal insufficiency is an important cause. We're going to talk about that. Hypertriglyceridemia can cause acute pancreatitis, as we mentioned before in the previous video, but sometimes it can cause some abdominal discomfort independent of that. In the liver and kidneys, porphyria, a well-known cause of abdominal pain and GI symptoms in general, but not very common. Carcinoid tumors, not very rare, but not common either. And most of the time, these tumors originate from the GI, but it can originate from other sites as well. Disease in the liver and spleen and GI in general can include also another less common cause of abdominal pain and GI symptoms, stomach mast cell disease. And then outside of the abdomen, hypercalcemia, relatively common cause, so look for that. Carcinoid tumors, we talked about that, but sometimes they might originate in the lungs, probably the second most common site for carcinoid tumors. Heavy metals, including lead, mercury, arsenic, or cadmium poisoning. These can cause severe peristalsis and with a lot of GI symptoms, and they can mimic bowel obstruction at times, so we're going to talk briefly about that. Periodic fevers, less common genetic causes of periodic abdominal pain. Patient might have some other symptoms like fevers, sinusitis, synovitis, and rash. We'll talk about that. Angioedema, also you might see it. It could be hereditary, it could be acquired, and then might present with recurrent abdominal pain. So we are going to talk about a few of these causes. First one is DKA, probably the most common. GI symptoms are relatively common in acute classic diabetic ketoacidosis. It happens in the majority of patients, more than 60% of patients. Abdominal pain, again, relatively common. It's multifactorial, but acidosis probably plays a role in the pathophysiology of abdominal pain in DKA. And do not attribute pain to DKA all the time. Sometimes, especially if the DKA is mild, but the patient is having a lot of abdominal pain, think of another cause of both the abdominal pain and the DKA. Basically, another pathology happening inside the abdomen, like pancreatitis or any other inflammation or infection that triggers the DKA in diabetic patients. So don't always attribute abdominal pain that is from the DKA and ignore looking for a trigger inside the abdomen. As you know, by definition, making the diagnosis of DKA is usually straightforward. Sometimes can be a little bit tricky, especially in certain situations where the glucose is not very high. This entity known to be a cause of similar presentation of DKA is called euglycemic DKA, and it usually happens with patients with SGLT2 inhibitors, but it can happen with other situations as well. But usually, the 3 components of DKA, number 1 related to the hyperglycemia. Usually the glucose level is more than 200 milligram per deciliter, but again, it can be less than that in euglycemic DKA. And then the second part is the K, which is the ketoacidosis or the ketosis, and it's usually identified by finding elevated ketones, mostly the beta hydroxybutyrate. It can also, a surrogate of that could be the positive urine dipstick for ketone as well, if the beta hydroxybutyrate test is not available. And then the third component is acidosis, which is usually metabolic acidosis, and it's usually high GAP acidosis, bicarb usually less than 18 milliequivalent per liter. And this is mostly the criteria which is agreed upon by the various guidelines. So we're not going to talk about the details of DKA management and all that. Maybe we'll do that in a separate video. But, keep in mind that euglycemic DKA in patients with abdominal symptoms would be a little bit more challenging to diagnose. Another common pathology for abdominal symptoms include uremia. And uremia is usually a term used to describe signs and symptoms of advanced kidney disease or kidney failure. The GI symptoms not necessarily due to just a high urea or high creatinine, but usually there are a lot of uremic toxins, so to speak. There's a lot of them. This is just some examples, but usually the accumulation of these toxins is the reason behind the uremia symptoms in general, including the abdominal pain, which could be due to mucosal changes inside the abdomen, including edema or sometimes ulcerations and bleeding. These are relatively common in patients with advanced kidney disease. Common GI symptoms include loss of appetite or anorexia, nausea, vomiting, and abdominal pain, which is usually vague and diffuse, not very specific. A patient might describe it just like abdominal bloating or generalized abdominal discomfort. Widespread associated symptoms, as you know, patients with uremia that mostly affect a lot of organs. Almost all organs can be affected to some extent. But more common symptoms include fatigue, itching, sinusitis, including pleurisy, pleuritic abdominal pain, or pericarditis. And as you know, pericardial pain is an indication for dialysis, as most other manifestations of uremia as well. Mental status changes could be very subtle, like just personality changes or like depression or non-specific mental changes, but it could be dramatic as well sometimes with acute confusion or delirium. Muscle cramps, also a relatively common symptom as part of the musculoskeletal manifestations of uremia. Uremia symptoms in advanced kidney disease, again, generally could an indication for renal replacement therapy if the patient becomes symptomatic. But again, as you have noticed, that these symptoms are not very specific, very vague and generalized. So the good news is, basic imaging and testing, including kidney function test, renal ultrasound, electrolyte, calcium, PTH, other mineral bone disease in kidney disease, all these can be revealing and indicating that these symptoms are from uremia, and then in this situation, patient might need renal replacement therapy. Another metabolic cause, relatively common, of abdominal pain is hypercalcemia. That could be classified as mild if it's less than 12, or moderate if it's between 12 and 14, severe if it's more than that. Clinically, people like the famous mnemonic, again, hypercalcemia can affect many systems, and that's the origin of the mnemonic, bones, stones, abdominal groans, psychic moans or over stones, and cardiac rhythm tones, right? So people with hypercalcemia may have a lot of bone manifestations, including bone disease, muscle cramps, muscle pain. They have high risk for fractures with minor trauma or falls. Stones, is also common. They might present with kidney stones that could be cause of acute abdominal presentation. Also polyuria. Think about chronic hypercalcemia in patient with polyuria. Abdominal pain, again, could be severe, could be associated with nausea, loss of appetite. Patient might have constipation. Hypercalcemia can be a cause of acute pancreatitis on its own as well. Current severe hypercalcemia can also be a cause of underlying peptic ulcer disease. Psychic moans or overstones, patient might have some vague psychiatric or neurological manifestations like trouble concentrating, personality changes, mood changes. Heart is also can be affected. Patient might have some rhythm abnormalities including bradycardia, AV block, and short QT interval. Again, it's easily discovered with a simple blood test, but the caveat is with a single measurement of hypercalcemia, especially in patients who are sick or having other diseases, treat the underlying cause first, and then repeat the serum calcium after that. Many causes of elevation of hypercalcemia could be due to dehydration, for example, or patient is just sick. So to confirm hypercalcemia, repeat the test when the patient is more stable to confirm persistent hypercalcemia. And then you will need other tests like PTH is probably the first one that you order in if you want to sort out the underlying cause of hypercalcemia. And then you will need other basic testing like CBC, looking for anemia, for example, complete metabolic panel, looking for kidney function, electrolyte disturbances, phosphate level, vitamin D, like PTH-related peptide if you're suspecting hypercalcemia of malignancy. TSH and thyroid function tests could be associated with hypercalcemia. Urine analysis and urine electrolyte, including urine calcium, also could be indicated. And then imaging, looking for bone disease, or like chest x-ray, looking for underlying cause of chest problem associated with hypercalcemia, and like sarcoidosis, for example, and kidney ultrasound to look for underlying kidney disease. So maybe we can talk about hypercalcemia in another separate video, but this is kind of relatively one cause of GI symptoms. Another important metabolic cause is adrenal insufficiency. Again, not very common, but important to recognize and to keep in mind. GI symptoms are relatively common in adrenal crisis, and this patient can actually mimic patient with acute abdominal pain due to appendicitis or other classic cause. So keep that in the differential if the patient is not having like a really clear, straightforward diagnosis. Chronic adrenal insufficiency might be a little bit more challenging to diagnose. The symptoms are very non-specific, including abdominal discomfort, bloating, loss of appetite, weight loss. Can be easily missed in cancer patients because a lot of these symptoms can actually mimic symptoms in patients with advanced cancer. Clues for diagnosis: so a patient with unexplained poor well-being and or weight loss, just really vaguely sick, especially over weeks or months. Think about adrenal insufficiency. Unexplained fatigue, they're not really doing what they're usually used to do, just feeling tired. One, again, not very common, but important cause of that is adrenal insufficiency. The skin and mucous membranes hyperpigmentation in certain areas, like the palmar creases or like areas of friction. And usually the skin is dry in this patient as well. Also think of adrenal insufficiency. Salt craving, the patient is telling you that they notice that they like to add salt to their diet. There may be an indication for presence of adrenal insufficiency. Unexplained fever, unexplained hypotension. Again, this could fall under acute adrenal crisis. So think of adrenal insufficiency as well. Presence of other autoimmune diseases, especially thyroid disease, and then they're having other symptoms. Think about adrenal insufficiency as well. Fluids in the lab include normochromic anemia, lymphocytosis, eosinophilia also can happen with adrenal insufficiency, hyponatremia. We talked about that when we talked about hyponatremia, hyperkalemia. Again, these are classic but not present in all patients. Hypoglycemia as well, and hypercalcemia, usually mild but can happen with adrenal insufficiency. So keep this in mind. Think about adrenal insufficiency. Patient with very vague symptoms, very vague abnormalities in labs. Now, how to make the diagnosis? After you suspect adrenal insufficiency, you want to order the ACTH stimulation test or cosintrobin stimulation test with the plasma level of ACTH hormone. So you want to do it in the morning. So you take the morning level, 6 to 8 a.m., and then you administer the standard dose, 250 microgram of ACTH, and then you measure the level again after 30 minutes, and then after 60 minutes, an hour. So if the morning AM serum cortisol is less than 5 mcg per deciliter, and the ACTH is twice the upper limit of normal, you get the diagnosis of primary adrenal insufficiency, which is indicative of primary adrenal disease. And then, but if the level is above 5, and then you administer the ACTH, and then you check it again in 30 minutes, and it's still less than 16, or after 60 minutes, an hour, it's less than 18, if it's less than 18, and this also could still indicate adrenal insufficiency. And if the morning serum cortisol is high, it's basically above 18, this virtually excludes the diagnosis of adrenal insufficiency. So again, the main challenge I think is really suspecting it, and if you are suspecting it, just order the cosintrobin test and the ACTH and take it from there. Another important but less common cause of intermittent abdominal pain that might be a little bit difficult to diagnose because again it's not very common is porphyria. These, as you know, are disorders due to defective enzymes of heme synthesis. Heme basically is formed of porphyrin ring and iron. And as you know, heme is really incorporated in a lot of important proteins like hemoglobin and myoglobin. These could be autosomal dominant, could be autosomal recessive, some of them are X-linked, some of them they happen sporadically. So it's very variable. And they lead accumulation of porphyrins and porphyrin rings in different organs, lead to the constellation of symptoms associated with porphyria. And this accumulation usually happens in different organs, but mostly in the liver. And we call this hepatic porphyria, or they might accumulate in the RBCs or bone marrow, and we call these erythropoietic porphyria. The defective enzymes could be inside the mitochondria, could be outside the mitochondria. There's a lot of them, and they could be neurotoxic too, and can lead to a lot of neurological manifestations, more commonly motor neuropathy, but also can be leading cause of sensory neuropathy as well. And sometimes dysautonomia, like autonomic neuropathy. Acute hepatic porphyrias, these are the most common ones, maybe the ones that you might encounter. I have seen a couple so far in my career. These are autosomal dominant, and there are 3 of them: acute intermittent porphyria, AIP, hereditary coproporphyria, HCP, and variegate porphyria. These are part of the hepatic porphyrias, as you can see here, but there's other hepatic porphyrias as well. These are less common though. The most common among these after these 3 acute porphyrias is porphyria cutanea tarda. And then the other porphyrias are the erythropoietic porphyrias. Again, these are much less common than the hepatic porphyria and acute intermittent or acute porphyrias in general. Now, the most important thing is the clues to the diagnosis. When do you suspect porphyria as a cause of GI symptoms or abdominal pain? Usually, if there is like history of intermittent abdominal pain that's really undiagnosed in young patients, and there is some associated neuropsychiatric symptoms, or patient has some motor or sensory neuropathy. But motor neuropathy again is more common than sensory neuropathy, but both can happen. Think of porphyria in these situations. The abdominal pain usually diffuse, could be deep, aching pain as explained by some patients. and kind of relate to the back, kind of relate to the limbs. So as you can tell, it's really very, very non-specific pain. It could be very vague, but it's in acute porphyria, it's usually intermittent, and there is no such diagnosis and can cause some distress to the patient. Symptoms occur after triggers. So try to elicit from history if there's any trigger for the acute abdominal pain episodes. There's some medications like steroids and other porphyrinogenic medications, alcohol ingestion, any acute illness, low-calorie diet, especially instituted for weight loss. If the patient is starting to have low-calorie diet purposely to lose weight, that could be a trigger too. And of course, family history of similar episode or even diagnosed porphyria, that would be very helpful if available. Some patient might have hypernatremia, it might mimic like SIAD. Sometimes it might be a little bit hypovolemic. Think about that as well. Again, it's kind of a really very rare cause of persistent hypernatremia, I would say. Now, how do you diagnose porphyria? If it's suspected based on the clinical scenario, measure the urinary porphyrin precursors. There are two of them, two precursors you need to measure. It's aminolevulinic acid, ALA, and porphobilinogen, or PBG. Measure those in a spot sample of urine. PBG is almost always high in acute attacks, and it's a sensitive and specific test, so it's very helpful during the acute episode, but could be challenging if measured between the episodes. Also, you consider ordering the urine creatinine as well, just to kind of correct and normalize the ALA and PBG levels for creatinine, because there's some variations in the urine concentration sometimes. And it's usually, again, more commonly in the acute episode, it's at least 5-fold above the upper limit of normal, usually much, much higher than that during acute episodes. Total urinary porphyrins, some people order that. It's helpful, order it, but don't order it alone, right? These total urinary porphyrin levels might remain high during longer than porphyrin precursors in certain porphyrias like CP and VB. So usually, therefore, it's useful to measure total urinary porphyrins in the same sample. But don't just order the urinary porphyrins alone. Measure the LA and the PPG, these precursors as well. So basically, the urine sample you're gonna send it for ALA, you're gonna send it for PPG, you're gonna send total urinary porphyrins and urine creatinine as well. And then further testing is needed to determine, of course, the type of porphyria, right? So you can order other specific serum porphyrins and fecal porphyrins and genetic testing to determine the actual cause of the porphyria or the actual type of porphyria once your screening testing came back positive. Another cause of recurrent abdominal pain is angioedema. There are different types of angioedema. We're not going to talk about all of them, but really just briefly, you probably will see a case of angioedema. Maybe less commonly, you'll see a case of recurrent abdominal pain from angioedema, but it's not really very rare. So basically, angioedema is a transient local swelling of the skin that usually originates from the deeper dermis and subcutaneous tissues, and also local swelling of the mucous membranes. Usually not being painful, and usually there's no redness associated with it, just a swelling. There are different types, as I said. The most common one is the histaminic type. It's usually associated with some certain triggers and medications. But the one that's usually associated with recurrence and usually seen in younger patients are the hereditary angioedema. And there is the acquired type as well. The acquired type is really rare. It's usually not associated with urticaria, and usually there's no family history of angioedema. And it's usually diagnosed at a later age. You can see it in elderly, and you have to look for evidence of autoimmune disease or lymphoproliferative malignancy in these patients. Again, it's probably the least common cause. But hereditary angioedema is an autosomal dominant deficiency of C1 esterase inhibitor. And C1 esterase inhibitor, as most of the other reasons, it usually degrades the complement system. So any deficiency of this enzyme can lead to overactivation of the complement proteins and then activation of a cascade of inflammation, and that can lead to the swelling and the angioedema. In hereditary angioedema, usually there's a positive family history, but not always. It's usually diagnosed at early age. Patient is usually younger, usually less than 30 years old. And again, it's associated with episodes that are usually recurrent, and it happens most commonly in the skin of the abdomen and the extremities, but also can happen in the face, including the upper airways, which could be dangerous, and oropharynx. The one in the abdomen is the one that brought this angioedema topic here, because it can really present with recurrent abdominal pain in a young patient without a really clear cause. So It's one of the less common differential diagnosis that you have to think about in these situations. Then, in the involvement of the abdomen can also involve the genitourinary tract. So always ask about that, and also examine the genitalia when you examine the abdomen. Also extremities, the upper extremities, lower extremities can be a site for hereditary angioedema. The episode usually peak within 24 hours, and then usually resolved by the third day, within 72 hours. But it can last a little bit longer. It can last maybe up to 5 days, but it's a little bit less acute. It's like a little bit indolent compared to the histaminic type. So again, it's usually not associated with urticaria or pruritus. That's why it's considered part of the non-histaminergic angioedema, or sometimes it's called bradykinin-mediated angioedema. The histaminergic angioedema is more common and more acute in onset, as we talked about. Ask about exposures. Stress can induce this episode: surgery, trauma, infections, fatigue, tiredness, menstruation in females, drugs exposures, and food exposure as well. So try to tease out from history if there's any particular trigger before this episode of abdominal pain or GI symptoms, or mucous membrane or skin swelling. Ask about prodromal symptoms. The patient might have those, for example, localized tingling in the area that's going to have the edema, sense of skin tightness, fatigue, flu-like symptoms, mood changes in some patients, including malaise, irritability, thirst, and nausea. So very non-specific symptoms. Ask about those as well. A diagnosis, usually if you suspect this, again, maybe in a young patient with recurrent abdominal pain, without a clear cause, and there is some episode of swelling and angioedema in other parts of the body, think about hereditary angioedema and consider testing for the C4 levels, usually low in these patients, and also check for the C1 inhibitor antigenic level, usually less than 50%. And you can check also the functional level, which also will be reduced in these patients. And the treatment is, again, if it involves the upper airways, consider ICU admission. You have to replace the enzyme, so you have to give C1 esterase inhibitor. Usually they have poor response to epinephrine, corticosteroid, or antihistamines compared to the histaminic or histaminergic angioedema. Keep that in mind. Watch for rebound symptoms. They might need to be watched in the hospital or in the ICU for a little bit more hours after the resolution of symptoms. And then when you discharge this patient, refer them to allergists for more definitive treatment and testing for more particular triggers. Another cause of abdominal pain that might or might not be seen in abdominal imaging, actually, carcinoid tumors. These are part of the neuroendocrine tumors. This is a very broad term. They usually originate from the neurocrest or neuroectoderm and endoderm. Examples of those include insulinomas and gastrinomas and carcinoid tumors. For carcinoid tumors, they usually originate from the GI tract and pancreas, but also can occur in the lungs and thymus and other less common areas. They usually secrete serotonin and other bioactive substances, and these are the cause of the symptoms of these disorders. It's usually rare, and it's usually indolent, but can be aesthetic as well in few cases. Patient can be asymptomatic, but if they start to secrete serotonin, they might have some symptoms. Now, if the growth itself can cause local symptoms depending on the organ affected, right? So if it's in the lung, might cause some shortness of breath or chest pain or obstructive pneumonia. Again, it can happen in the GI tract, like in the stomach, in the small bowel, can cause some small bowel obstruction in some few cases, colon as well, and genitourinary tract. So depending on the site, local growth can cause some local symptoms. The carcinoid syndrome is usually when the serotonin is not integrated in the liver because of liver disease, and thus the serotonin will bypass the hepatic circulation and go into systemic circulation and can cause some symptoms. And this is where the patient might have some recurrent abdominal pain and other GI symptoms like diarrhea and weight loss. So it could be a cause of recurrent abdominal pain without an obvious cause. But because of the presence of the serotonin, which goes to the other system, they might have some other symptoms in other systems that might give you clue to the diagnosis, like bronchospasms. They might mimic asthma in some patients. Skin flushing could be a clue as well. Usually affect the upper body, the neck, and the upper torso, and the face, and can last for 30 seconds to 30 minutes. That can persist for days in some patients. And then also another clue is the carcinoid heart disease, which is right-sided valvular disease and right-sided symptoms of right-sided heart failure symptoms. Triggers could be alcohol, chocolate, cheese, and wine. Some patients who ask about those. And the diagnosis is by checking the serum serotonin, that's usually high. Check also urinary level of 5-hydroacetic acid, or 5-HIAAA. Also consider imaging the abdomen, common sites, again GI and the chest. So consider imaging of the abdomen and the chest. MRI usually preferred because usually CT scan can miss some smaller tumors. But even better is the functional imaging CT scan. This can really detect active tumors in, again, the chest or the abdomen based on the location. And then, of course, once you determine there's a mass or tumor, you need to confirm the diagnosis by biopsy. Another rare cause of vague GI symptoms with other involvement of other systems as well is systemic mast cell disease or systemic mastocytosis. It can be a little bit challenging to diagnose, but again, thanks God, it's rare. Part of mast cell activation disorders, which result from the D816V mutation of the KIT gene. This KIT gene is basically encodes the receptor tyrosine kinase protein. So as it is a defective protein, there is usually persistent activation of the tyrosine kinase, and this will lead to the uncontrolled proliferation of mast cells. It usually happens in the skin, in the bone marrow, and the GI tract as well, causing some GI symptoms, and that's why we're talking about it here. Again, secretes mast cell mediators, especially histamine. Clues to diagnosis, again, can be very vague, can be difficult to diagnose. A lot of systems can be involved, and usually waxes and wanes. That's another clue. So if you have a patient with recurrent GI symptoms with other symptoms in other organs, think about mast cell disease, systemic mast cell disease. So can involve the upper or lower GI. Patient might present with septic ulcer disease and diarrhea or malabsorption. In the skin, patient might have flushing, itching, sweating, dermatographia. So when you press on the lesions, it actually extends, can produce more lesions. And patient might have urticaria pigmentosa. Very characteristic, as also common. There is a Darier's sign, which basically if you rub the suspecting lesion, you're going to have like a local reaction with increased erythema and worms at the site. Characteristic, if you can elicit that would be helpful. In the nose and local ocular areas, patient might have like red eye, rhinitis, itchy nose, runny nose. Also can mimic asthma. So think about it in patient with asthma-like symptoms and abdominal symptoms. The heart could be associated with non-specific symptoms like tachycardia and palpitations. Neuropsychiatric symptoms can happen as well. Patient might have some numbness, tingling of the upper or lower extremity, poor concentration, memory issues, and anxiety, depression, mood changes, bone pain, fatigue, very vague and localized symptoms, and symptoms may be intermittent or more chronic and persistent in nature. Diagnosis, again, can be difficult. The National Comprehensive Cancer Network guidelines suggest to look for one major criteria plus one minor criteria or the three minor criteria. Bone marrow exam is really crucial, so it's needed for the major criteria. So there's a characteristic pathological finding, including the presence of multifocal dense infiltrate of tryptase and or CD117 positive mast cells. The involved organs, more than 15 mast cells in aggregate, seen in the pathology report. And again, can be seen in the bone marrow or other organs. Biopsy of these were taken. The minor criteria include the presence of more than 25% of mast cells with atypical morphology in lesional tissues, the presence of the KIT D116V mutations or other activating KIT mutations that involve organs as well, apparent expression of CD2, CD25, and or CD30 on neoplastic mast cells, serum tryptase level more than 20 nanogram per ml, in the absence of an associated myeloid neoplasm. As you can see, this is all like pathological diagnosis, so it's really, you need to suspect it first. You need to look for consider bone marrow exam, and then also tissue biopsy for the other systems, other organs involved. Another cause is heavy metals, specifically lead poisoning. That used to be common cause, but not anymore. But it's still present. You have to think about it. Other metals include mercury and arsenic poisoning as well. They can be acquired through inhalation or ingestion. High-risk industries, think about those in patients who work in certain occupations, including battery manufacturing, construction, plumbing, painting, shipbuilding, secondary smelting, and refining of non-ferrous metals, and living in old houses. Also, other high-risk behaviors or jobs, including patient with history of use of illicit drugs, or use of herbal medications, drinking water depending on the area, and also a patient with history of retained bullet in some situations. Clue to diagnosis, again, it's usually multi-organ. Symptoms can be very non-specific, could be acute, could be chronic. So, for example, in lead poisoning, neuropsychiatric symptoms can happen. Patient that might be mild. Patient might have headache, fatigue, sleep disturbance, behavioral changes, irritability. Sometimes could be very severe, like encephalopathy, seizures, and coma. GI is also involved, so patient might have recurrent abdominal pains, sometimes called colic, nausea, vomiting, loss of appetite. Hematological manifestations include microcytic anemia, more common in kids. Hemolysis also can happen, but usually when the lead level is really high, causing direct damage to the RBCs. Other manifestations include arthralgia, joint pain, and also wrist drop, gingival and tongue hyperpigmentation. Look for those in exam. Kidney disease, reproductive disease, and cardiac disease as well. Diagnosis by checking the whole blood level. If it's usually more than 5 mcg per deciliter, this is usually considered abnormal. But level does not necessarily correlate with the severity of the symptoms. Again, it really needs like a high index of suspicion. Occupational history and exposure really important in these situations, and then some other clues like microcytic anemia, as we mentioned. Another characteristic cause of abdominal pain, recurrent abdominal pain, also less commonly seen. I personally have not seen one yet, is periodic fevers. Probably the most common one is familial Mediterranean fever, or FMF. These are a group of inherited disorders. You might have some positive family history in about half of the cases. Again, familial Mediterranean fever is probably the most common one, but there's other less recognized syndromes have similar presentation. For example, cryopyrene associated periodic syndrome, tumor necrosis factor receptor associated periodic syndrome, and others. Really important clue with that is the patient might be coming from like a Mediterranean area. That's really very important clue. So it's more common in Jewish people, Arab people, Turkish people, Armenian people, and Italian people as well. So people around the Mediterranean area has higher risk. So that's important clue for the diagnosis. And it's characterized by recurrent, usually unpredictable episodes of fever, and this episode might last for a day or up to 3 days. And it's a little bit difficult really to diagnose because it's very non-specific presentation. And pseudositis is very characteristic, including pericarditis, pleurisy, but also peritonitis. And abdominal pain is actually very common in these patients, and that's why it's again important to keep in mind in the appropriate patient population the differential diagnosis in recurrent abdominal pain, especially if it's associated with fevers. The episode of abdominal pain can range in severity from dull aching pain and distension with mild tenderness to severe generalized pain with absent bowel sounds, rigidity, rebound tenderness, and air fluid levels on upright radiograph, almost looking like acute abdomen. So it could be mild, it could be severe. CT scanning may demonstrate a small amount of fluid in the abdominal cavity because of the inflammation. Other clue in the diagnosis is the involvement of other systems, including the synovial joints. So a patient might have arthritis. It could be acute monoarthritis of large joint. It could be chronic, like chronic hip pain in some patients. Cutaneous inflammation also, they might have some redness and inflammation in different areas of the skin, including like a erysipeloid erythema of the dorsum of the foot, ankle, or lower leg. So as part of the differential diagnosis in patient with swelling, explain the swelling in the extremities, like maybe sickle cell anemia and tendinitis and other rheumatological disease. So keep that in mind. Later in some patients, they might actually develop amyloidosis, which could also again involve other systems as well. And other features include exercise-induced myalgia. It's relatively common in these patients. Some patients might come with aseptic meningitis, but it's not as common, and sometimes as vasculitis as well. And if you do inflammatory molecules in these patients, almost always going to be elevated. So as you can tell, it's really difficult to diagnose. Different criteria. One of them is the clinical criteria. The major features include recurrent fever, abdominal pain, because these are most common features, chest pain, joint pain, and skin eruptions. Minor criteria is not specific, including elevated ESR, leukocytosis, and serum fibrinogen levels. And the diagnosis can be confirmed with genetic testing, molecular genetic testing. Try to identify the biallelic pathogenic variants in the Mediterranean fever gene. But it's important to know that about 25% of individuals with familial Mediterranean fever may have only one identifiable pathogenic variant, not the two of them. And if the genetic testing is inconclusive and this diagnosis is still suspected, maybe consider just 6 months trial of colchicine therapy to see if that's alleviate the patient's symptoms. So in summary, this is just kind of some of the tests to consider depending on what you're suspecting in patient with recurrent unexplained abdominal pain especially if they're young, especially if they have involvement of other systems. So consider causing trouble test and ACTS testing if you're suspecting adrenal insufficiency. Always think about ruling that out. Check serum C3, C4, and C1 esterase level if the patient meets criteria for, or have some features of angioedema or angioneurotic edema. Consider testing for lead and heavy metals as well by testing the whole blood level. Spot urine for porphyrin precursors, P, PG, and ALA, and total urinary porphyrins if you're suspecting porphyria. And then in patients who have features suggestive of carcinoid syndrome, check 24-hour urinary IAA. And then serum tryptase level and bone marrow exam if you're suspecting systemic mastocytosis. Again, these are a little bit less common, but it's important to note. Abdominal pain can be very distressing to your patient, so in the appropriate clinical setting, think about rare things. They are rare, but they do happen.